Well, thanks everybody for joining. I'm Christie Morrison, and I'm a member of the GAP MASLD Community Network. And today, well, let me figure out if I can advance my slides. There we go. So if you haven't already registered for the meeting, you can register here. And today we're going to be talking about MASLD and MET-ALD. So we're going to start with a case study, and this is about Ashley. Ashley is a 52-year-old female who comes in for an evaluation because she had an abdominal ultrasound that showed some mild hepatomegaly and increased hepatic echogenicity consistent with steatosis. And so this is a very common type of consult that you may get in your office very regularly. She states she's feeling well. She doesn't have any complaints. She's 52 years old, female, Caucasian. She does have a BMI of 29.4. When we look at her past medical history, we do see she has some comorbidities. She's got PCOS, which unfortunately does increase her risk of obesity and even diabetes. She also has high blood pressure and high cholesterol. On physical exam, we see that her abdomen is very smooth, non-tender. When we palpate and percuss her liver borders, her liver edges are smooth. We do get a history of her substance use, and she admits to about 2 glasses of wine every day. And then with medications, she's taking amlodipine, atorvastatin, a multivitamin, and milk thistle, which very commonly our patients will come to us starting as they've heard that it helps with liver disease. We know based on her history here too she is taking medications for the high blood pressure and high cholesterol, which I think is important to point out. We get her vitals, and we do see that despite her high blood pressure medication, her blood pressure is still a little high. So she's got blood pressure of 140/78. Resting heart rate is pretty normal though, 76. Temperature is normal. Her weight is 161 pounds. And as we mentioned before, we did calculate that BMI of 29. Liver enzymes are a little elevated. So our ALT is 46, AST is 55, alkaline phosphatase is 140, total bilirubin is 1.2. Platelets are within normal limits at this time, but she does have an elevated A1C of 5.9, and her triglycerides were also very elevated at 185. We send her for a FibroScan, and we do see that she has an 11.4 kPa, which we know is a sign of fibrosis. And if we look at our recommendations, we can actually see that that's consistent with significant fibrosis of F3 fibrosis. We also get her CAP score, which is 310, which is definitely severe steatosis. So she's got a combination of severe steatosis along with already F3 or significant fibrosis. So let's talk about steatotic liver disease. Steatosis, of course, is the other word that we use for kind of inflammation in the liver, right? And we now are using different nomenclature than in the past, where we think about metabolic dysfunction associated steatotic liver disease, along with alcohol associated liver disease. So MASH, of course, is where the steatosis part is the fat, and then MASH is now where we're having steatohepatitis, which is now inflammation of the liver associated with that. When we look at MASLD and alcoholic associated liver disease, we think about, especially in a patient like this one that we just went over, she probably has a combination of both, right? So we know she drinks alcohol on a regular basis, but she also has multiple cardiovascular risk factors that, along with that obesity and signs of steatosis on imaging, do put her in the category for MASLD alone. So when we think about weekly alcohol intake, if we see greater than 350 to 420 grams, we think of alcohol intake, we think that that's more alcoholic liver disease predominant. Whereas if they have less, which is around 50 to 60 grams daily, then again, that's more alcoholic liver disease predominant. But if we think about it on the lower end, where they're having more 140 grams or 20 to 30 grams daily, that's more MASLD predominant, okay? Unfortunately, it doesn't matter really what the cause of her symptoms are. She still is at significant risk of advanced liver disease. She's at risk for other causes that we would need to make sure we're ruling out as well of both steatotic liver disease and steatohepatitis with other, autoimmune diseases. So we need to make sure that we're not missing that. And then, of course, other causes could be drug-induced liver injury, other monogenic diseases, and other miscellaneous causes. So let's look at the differences between alcoholic beverages. And this is something that I always like to review with my patients too, because very commonly they'll say to us, I only have 2 glasses of wine every day. But when we think about how much alcohol is in each different source of alcohol, and then we actually think about the size of the serving of alcohol, a lot of our patients are really surprised that they might be actually drinking for that 1 glass of wine. She might be actually consuming really 2 or 3 of the typical serving sizes of wine, right? So beer, of course, commonly is the one standard can of beer for for the typical equivalent of what's a normal serving of beer, 12 ounces. Unfortunately, nowadays, some of the cans are bigger. So we have to remember that. And when we're talking about serving sizes with patients, we want to make sure we're asking them about the size of their glass, the size of their can, so we can help determine exactly how much alcohol they're getting. Beer is probably the lowest content of alcohol with 5%. And then we kind of move across this table here with increasing amounts of alcohol as we go down the list. She's admitting to wine. We're not sure if it's like table wine or fortified wine, probably table wine because that's the most common. Sherry and ports are a little bit sweeter, so people may consider those to be more of a dessert wine. So table wine, of course, we see 12% alcohol with only 5 fluid ounces being one serving of table wine for alcohol. So again, this would be a question where I'm going to ask this patient, what size of glass are you drinking for your wine and where are you filling it up to, right? And we all know that those sizes can vary. So this is something that we really want to make sure we're asking her. We want to do this with every serving of alcohol as well. Malt liquor, which is very common nowadays with some of our drinks like the malt liquor cans that are out there that are very popular. And then, of course, we have the aperitifs, the actual harder liquors like brandy, cognac, and then we really move into, the alcohol that has the most amount of alcohol in per serving, which is our distilled spirits like our vodka, gin, tequila, things like that. So now, for this patient, we're thinking maybe she has a dual etiology of steatotic liver disease. She definitely has some risk factors when we think about MASLD, right? So even though she doesn't have a history of diabetes, we know her A1C is elevated. So she probably is developing some insulin resistance. She is obese and has increased visceral fat. We don't know what her diet is. We haven't discussed that with her, but we know that eating unhealthy foods like high processed foods, fast foods can increase your risk factors for MASLD. Sedentary lifestyle, which unfortunately a lot of our patients have these days since COVID, a lot more patients are working from home and not working outside of the home now. There are definitely some genetic susceptibilities that can increase the risk of NAFLD and MASLD as well. And then alcohol intake, we know, is of course going to increase that risk. So all of those risk factors, including alcohol, increase the risk of impaired lipid handling in the liver, which then increases stress and cell death. And unfortunately, will cause some inflammation and scarring in the liver over time. When we think about the disruptions in the intestinal microbiome from alcohol, that also unfortunately increases risk in the liver because of the inflammatory response that occurs. We have more neutrophil-mediated immunity, which activates those macrophages and accelerates fibrosis and disease progression in liver disease. So unfortunately for our patient that we've already discussed, she not only has some of those MASLD risk factors, but now when you add in the alcohol with that, she's just setting herself up, unfortunately, for really risk of advanced liver disease and faster progression of liver disease. So when we think about drivers of liver disease over time, we want to, think about the staging, as we mentioned, and we're able to stage her already with F3 fibrosis. We think about those metabolic risk factors with obesity, insulin resistance, dyslipidemias, and hypertension. We think about genetic risks and then alcohol use. And we want to try to help our patients modify the actual modifiable risk factors as much as they can. Genetic risks, of course, cannot be modified, but alcohol use and some of our cardiometabolic risk factors can. So in this patient, we're going to be talking to her about those to make sure we're really decreasing the risk anywhere that we can. When we look at our fibrosis stages, we know that she's already at an F3 fibrosis. And somebody with just MASLD, she has a 5 to 15% risk of increase to decompensated liver disease over the next 5 years. But when we have somebody with MET-ALD, which is the combination of MASLD and alcohol-associated liver disease, you can see that that 5-year risk significantly increases now at 10 to 30% compared to just 5 to 15%. Because she's already at F3 fibrosis. And then if she only had alcohol-associated liver disease, the 5-year risk increases again to 15 to 50% over 5 years risk of progression to decompensated liver disease. So our patient that we're dealing with today is in that middle spectrum, so 10 to 30% risk of progression to advanced decompensated liver disease over the next 5 years. These are the numbers that we want to be sharing with her in order to help her understand how important it is to change and make the modifications in her life to hopefully prevent progression to that decompensated liver disease, but also hopefully decrease fibrosis and reverse fibrosis over time. So in a patient like this as well, sometimes we can talk about sizes of alcohol to sometimes help them understand that really they may be getting more than they think they are. Most people think 1 to 2 glasses of wine aren't that much. Sometimes, though, patients will not even admit to liver or to alcohol use. And when we're in a patient like this that's F3 fibrosis, we really want to know what's going on that's driving this inflammation in the liver so we can help our patients get better. So again, we know that when we have fatty liver disease and then we add that combination of alcohol, that increases their risk of more advancing steatohepatitis, which progresses to cirrhosis. If she has type 2 diabetes, which we know she actually has prediabetes based on her A1C, that's a further risk, and then obesity increases that risk as well. So we can find out how much they're drinking by multiple ways. We can use questionnaires like CAGE. We can collect samples through serum and urine and even hair samples to determine if we're sensing the presence of alcohol. We know that when we get those results, we can kind of determine, how excessive their alcohol use is as well. And we want to make sure that we're really kind of using a combination of these to really optimize the diagnosis of whether or not this is just alcohol related or a metabolic associated liver disease. So again, let's look at the gaps that we have here. We know that we have a really good idea of things that cause metabolic dysfunction, and we have a really great idea of what alcohol disorder is, but the combination can be difficult. And so we think that, in this patient, we definitely have evidence of metabolic dysfunction. She's got the increased BMI, she's got the elevated fasting serum glucose or elevated A1C. Her blood pressure is also elevated. Her triglycerides were elevated, indicating poor control. And then we want to quantify that alcohol in grams to really assess how much alcohol she's drinking. Again, she mentioned 2 glasses of alcohol per week, but of wine. But remember, that's about a 15% increase or percentage of alcohol in each glass, and we actually don't know how big her glass is. We also want to consider if she denied any alcohol use, we could consider use of biomarkers like PEth. And then we need to also still make sure that we're excluding other differentials. We don't ever want to assume that the patient's only problem, if we're seeing elevated liver enzymes, which we are, is alcohol or metabolic associated liver disease. So we want to make sure we're not missing other either infectious or autoimmune causes of liver disease as well. So we did a PEth for her, and we see that she's got 20 to 200, um, you know, which is kind of a moderate to heavy alcohol consumption. So although she's only endorsing that 1 to 2 glasses of wine every day, either she's kind of fibbing on the amount or she's really having 2 really big glasses of wine every day. And that's okay. Maybe she doesn't understand that 1 serving is that, 6 ounces, but we're going to help educate her about this. And now we know where we are really falling with her alcohol use, so we can kind of give her the best information. We know that PEth can remain detectable for 3 to 12 days after one single binge. So this is a really good marker for us to use in the setting of alcohol. So even if a patient's been, alcohol free for the past 3 days, PEth will really tell us, on average, have they had a drink over the past almost up to 2 weeks, right? So this is a better way of determining their alcohol use on a regular basis than just doing a serum alcohol. We actually know that there's no significant variability between females and males and BMI, so we can really trust these results as well. Unfortunately, we think about absorption in individuals that have excess weight for anything. And so we want to wonder if, is she actually maybe even having higher alcohol levels based on her BMI, that she might not be absorbing as well as somebody that's a thinner individual. So there was actually a study that looked at this in individuals. 617 patients were enrolled. About 284 of those individuals did not drink, 333 did. And then we see here that patients that have that 140 to 350 grams per week in females and 210 to 420 grams per week in males were all having, that consistent PEth of greater than 25. And they did not meet any exclusion criteria. They were all tested for hepatitis B, C, and other sources of liver disease in advanced. 97 of those patients that were analyzed did have suspected MET-ALD, so that combination of metabolic associated and alcohol liver disease. So again, let's go back to our patient here. So she's got PCOS, which we talked about, unfortunately does increase her risk of other autoimmune diseases and significantly diabetes, high blood pressure, and hyperlipidemia. So 3 risk factors there. She's got the BMI of 29. She's averaging the 2 glasses of wine per day, but from her PEth, we know that she may be kind of under just cutting that what she's actually drinking there. We look at the association as well between alcohol and high blood pressure. We know that the alcohol that she's consuming actually might be worsening her blood pressure as well. In a randomized controlled, actually a systematic review of several randomized controlled trials with 767 participants, we measured alcohol use over time along with blood pressure, and we're able to see that alcohol kind of has a biphasic effect on blood pressure. Up to 12 hours after consumption, it can decrease the blood pressure, but in about the first 13 hours after consumption, it can actually increase the blood pressure. So although patients may, feel more relaxed, we actually are seeing their blood pressure go up for that first half of time while, after they've consumed alcohol. And then it takes about 12 hours for that high blood pressure to actually get better again over time. So in somebody that has underlying hypertension already, this can be dangerous as she may not even realize due to the effects of alcohol that her blood pressure is increasing. When we look at alcohol and triglycerides, we also know that alcohol can affect those as well. And this individual, she already has elevated triglycerides. So we think that she might be having worsening hypertriglyceridemia secondary to her alcohol use, as we can see here in the groups that are in blue. The elevated levels of ethanol compared to the actual plasma triglycerides, which we see increase over time. So we're looking at the blue squares as the non-triglyceride elevated use of ethanol, and then we look at the round blue circles as the ethanol, and you can really see a significant curve here in that increase. So we'll go back to our patient again. 52-year-old female, initially saw us because of hepatomegaly and increased steatosis. She overall feels well, but she's got this score of 11.4 kPa, which puts her in an F3 fibrosis score. She also has underlying risk factors of PCOS, hypertension, hyperlipidemia. Her liver enzymes are elevated, and she is, drinking with an elevated PEth. So probably more than that 2 glasses of wine daily. Our diagnosis for her is going to be MASLD, but she does have predominant MET-ALD. So that means her alcohol-associated liver disease is combining with just typical MASLD to make MET-ALD diagnosis. So what are our current treatments going to be for her? Obviously, we want to talk about diet and lifestyle modifications, right? So we want to get her blood sugar under control, which are going to in turn inform her triglycerides a little bit and improve those. Mediterranean diet, of course, is still recommended for any patient with MASLD, including patients that have alcohol use. So we're going to be recommending the Mediterranean diet. We're going to recommend exercise and weight loss. And this patient is a candidate for resmetirom, right? So she has F3, F2, or F3 fibrosis. So what are we going to do about alcohol use? We're going to recommend she stop completely, right? So even though she's only endorsing 2 glasses of wine per day, her PEth is indicating a very high, much higher levels of alcohol over time. And we know that that's increasing her risk significantly compared to MASLD alone of progression to decompensated liver disease. Does she need HCC screening? Absolutely. So we need to consider HCC screening not only in patients with cirrhosis, but also in our patients that have stage 3 fibrosis, because we worry about progression to cirrhosis rapidly. And so HCC screening is warranted here. We also, unfortunately, do see some increased risk of HCC in F3 fibrosis alone. So we need to go ahead and start screening her every 6 months with an ultrasound. The ideal MET-ALD definition for clinical trials is going to be based on those objective biomarkers, right? So we can't really depend on patients to give us a good idea of what kind of alcohol use that they're consuming on a regular basis, because they do tend to underreport. So PEth is going to be a better marker of that for us. So we'll use PEth to standardize the recent alcohol use and really certify, are they really abstaining from alcohol or are they not? With the alcohol that they're consuming, it also gives us a good idea of how much they're consuming on a regular basis. We want to ensure that there are no other drivers of liver disease present. For her, we know that she's got at least one cardiometabolic risk factor. So that, in the combination with the presence of steatosis on imaging, gives us the diagnosis of MASLD. And so we want to ensure that we also, after we stop alcohol use, that she still has high blood pressure and high hyperlipidemia. Because we know that alcohol can increase those risks, it's possible that the blood pressure and her triglycerides may improve after she discontinues with alcohol. We also want to consider her exposure to other risk factors, and we want to review those fulfillment of that criteria during the last 6 to 12 months. So what are our take-home messages for patient? We have the new definition, which is metabolic associated liver disease, and it includes alcohol intake of beyond 140 to 350 grams or 210 to 420 grams per week in women and men, respectively. We want to make sure that we don't underestimate the MET-ALD risk. So we're not just considering MASLD anymore. We need to make sure that we're really considering MET-ALD in our patients that consume any amounts of alcohol, as that combination does significantly increase their risk of progression to decompensated liver disease. Remember that we can't rely on a good history when it comes to alcohol use, so we need to be using our biomarkers like PEth to really determine what their level of alcohol consumption is and ensure that the other drivers of liver disease are present even in the absence of alcohol. So if they are able to abstain from liver disease over time, we may actually see some improvement in their other risk factors, such as their hypertension, hypolipidemia, or obesity. So we want to make sure that we're reassessing that over time and making sure that we are considering adequate exposure to those risk factors within the past 6 to 12 months. Any criteria for clinical research should facilitate those objective MET-ALD diagnoses and allow for comparisons among different sociocultural realities. So we want to look at our, different cultural variables across the country within different communities. So thank you guys for joining us tonight as we spoke about MET-ALD and MASLD. I know it can be a little confusing but it's definitely very common. And if we can identify these risk factors and identify MET-ALD in our patients early on, we can really, diagnose them appropriately, but also counsel them and make the appropriate changes that could potentially prevent them from progressing to that decompensated liver disease, which they do have a higher risk of. So thank you guys for joining so much. Continue to carry these principles back to your practice and discuss them with your patients. Also visit our GAP and MASLD MASH Community Network for additional disease state education, as well as the ResDiff for a webcast, and consider using that in your patients when appropriate. You can scan this QR code to provide a short survey to talk about your thoughts on my presentation today and give us insights to help us improve not only here, but any other educational initiatives related to MASLD and MET-ALD that you would find appropriate. Thanks so much.